I'm really trying to hit trigeminal neuralgia hard right now with the research
Yeah.
reviews just to kind of build up a bunch, what's out there and what's available, at least for now. Even get some more awareness out there and especially get it aware for people that have trigeminal neuralgia. Try to get them because nobody's telling them about this, let's be honest. And
No.
it's really sad. So hopefully they'll run across this video and they'll see that there's a conservative option that could potentially literally change their lives. It would be priceless. It would be priceless to people that are suffering with this, so that they have more answers. Hi there, I'm Dr. Kevin Leach here with the Chiropractic Deep Dive Podcast, bringing you the most important research and information on conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic care. These research reviews, interviews, and episodes are made for you, whether you're a medical doctor, patient, or concerned family member or friend. The goal of these shows is to bring awareness of the importance of taking care of our spine and the impact it has on our health and the hundreds of different health conditions it could cause without us realizing it. I'm really trying to bring value with these, so I'd appreciate commenting on the videos, hitting the like button, and sharing them with as many people as you can. You never know who might need to see it. And consider subscribing to the channel so you can see all the other episodes and videos coming out. Thank you so much. I truly appreciate your support. Now on to the show. Okay, welcome back everyone to the Upper Cervical Chiropractic Research Show. This is episode 22. I'm Dr. Kevin Leach, and here with me once again is Dr. Tyler Evans. How are you, sir?
Hello.
All right, so today's research review title is Trigeminal Neuralgia and Chiropractic Care, a case report by Robert J. Rodine and Pierre Aker, and published in the Journal of the Canadian Chiropractic Association. Yeah, so the goal of this paper obviously is just to bring more awareness to how chiropractic adjustments and chiropractic care can, what it can do for patients with trigeminal neuralgia. So Dr. Evans, you've reviewed this paper before on your own little research show that you do, or research moment, I think you do for your practice. So what about this paper, if anything, specifically interests you?
Well, you and I both have talked about it many times, but we see trigeminal neuralgia patients. Trigeminal neuralgia is, it's hard to say because we've never experienced the pain, but people say it is the suicide pain. It's the worst pain you could experience. It's that ice pick through the face and that trigeminal nucleus, which is the largest bundle of nerves in our skull. And when it's aggravated, it's nasty. And so, getting the word out to these people that there are solutions other than drugs or surgery is always something that, I get excited about. Because sometimes we can help these people, not always, and sometimes in partiality and there are other pieces to it, but if we can at least help these people a little bit, honestly, you're saving lives. Like,
absolutely.
Saving lives.
Yeah, nicknamed the suicide disease because
Yeah.
of how excruciating the pain is. Absolutely.
Yeah.
Let me read just the intro real quick, just a little bit of background about the case study, and then we'll go into it a little bit more. So 68-year-old woman with a 7.5-year history of worsening head and neck pain, diagnosed as trigeminal neuralgia following surgical resection of a brain tumor. After years of unsuccessful management with medication and physical therapies, a therapeutic trial of chiropractic was carried out. Chiropractic care included ultrasound, manual therapies, manipulation and mobilization, soft tissue therapies, and home stretching exercises. After an initial treatment period followed by 18 months of supportive care, the patient reported satisfactory improvement. A little bit further down, while never completely pain-free, the patient continued to report that her pains reduced to minimal at times. At the most recent follow-up, the pain had not returned to pre-treatment intractable levels. And for those who don't know what intractable means, intractable just means not treatable. Like if no medications, no treatment therapy, like nothing's touching it, you just have to wait for it to carry out and go away.
Yeah, and I think it means it doesn't go away. Like the pain doesn't go away.
Right.
Yeah.
Intractable. Right. Potential for convergence of sensory input from the upper 3 cervical segments and the trigeminal nerve via the trigeminal cervical nucleus is discussed. That's the outline of this case study. And like you just said a moment ago, not everybody's going to get complete, absolute resolution. But if you can improve quality of life and get it to where it's not intractable, get it to less days and all that stuff, it improves quality of life and drastically can change and save people's lives. What else would you say about this? Is there any other points or anything just in detail that you think is important here?
I think an understanding of why we might be able to help is just because C1, C2, and C3 have nerve fibers that actually run up into, so there are nerve fibers that come out of C1, C2, and C3 on they're the dorsal nerve roots. At that level, they are directly ran up into the trigeminal cervical tract. And that then goes into the nucleus, which is up here. And then the nucleus turns into the 3 branches. So V1, V2, and V3. So V is trigeminal nerve, which is cranial nerve 5. That's why it's V. So V1, V2, and V3. So people's patterns of pain may show up in one of these 3 segments. Usually it's these bottom 2, but sometimes it'll be more, or sometimes it'll be in the top one. And oftentimes it's more in ladies. I'm not sure why, but it tends to be more in females than males. But I could hypothesize, but I would say that probably has to do with the size of the neck and the strength of the neck in accidents, because this woman, she had a brain surgery, which needed to be done. It was over on the left-hand side up in the cortex over here. She had if you look at the MRI there, it had eaten through the skull almost. So anyways, they did that surgery over here. Probably during surgery, her neck, it happens. So many patients go through surgery and they come out and their necks are out of alignment just because you're unconscious. They're moving you around and things kind of slip out of place. I see that all the time. You probably see that too. So that happened, right? And then she developed the pain. And
well, I think it's interesting. The tumor was on the left side and her symptoms are on the right. So there seems to be a correlation because she developed it after the surgery, but there seems to not be, and it's probably because of maybe a patient, a position or something that she was just stuck in for an extended period of time and was unconscious and wasn't aware enough to say, hey, this hurts, I need to, move this or whatever.
Right, exactly. And that's a common thing I see, with dental. And it's nothing against dentists, or surgery or anything like that. I know, sometimes people have to go under, but when you go under, just know if you're an upper cervical patient or if you develop back pain or neck pain afterwards, it's really important to get your spine checked afterwards, because most of the times my patients go under, they come out of alignment after surgery or during surgery, and they come back in and they're like, man, I don't know what happened. I'm like, a month ago, what was going on? Oh, I had that, pacemaker put in or whatever. Anyways, just things to be aware of. And like I said, female, smaller neck, vertebra are smaller, muscles are smaller, much easier to misalign. We see that in whiplash. We see that in concussions. Again, C1, C2, and C3 have direct nerve impact into that nucleus. If we get those vertebrae balanced, it can help.
When you have a patient, and a patient comes in and they've heard about it, they've watched the videos, but maybe they just don't really understand C1, C2, trigeminal cervical nucleus, blah, 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 medical stuff. How would you simply describe to them, hey, doing what we do here could potentially help? Do you have any analogies or anything that you use in practice that could help people understand?
Specifically with TN or just
TN or just maybe, headache.
Yeah, well, I would say that with the upper neck, the main thing chiropractors are doing is balancing the spine to relieve nerve interference to get brain to body communication back, which the brain heals the body. That's what the brain does all day long. If the spine's out of alignment, the nervous system isn't able to do its job. What we do is we go right to the source underneath the skull, where C1 and C2 are the most easily compromised vertebrae in the spine. They're the most mobile joint, it's the most dynamic joint, but it's the most complex. It requires a very specific correction, and it can be knocked out of place via trauma or just stresses, their chronic stresses over time. And that could be, being under during surgery. And when they come back out, their neck's out of alignment, C1, C2 come out more than any other vertebra in the spine. They move more than any other vertebra in the spine. So if there's going to be a misalignment and it's going to affect brain health, it's going to be at C1 and C2, possibly C3, but more than likely C1 or C2, maybe pulling C3 with it. And then it's going to impact that cervical nucleus, which is the largest nucleus in the skull, and taking all that information. And that cervical nucleus, that trigeminal cervical nucleus, it pushes into the skull, and we get head pain, people get headaches. We'll do a paper on that in the future. I know Dr. Leach and I talked about doing it on cervicogenic head pain that can be driven by that nucleus. So it's just getting those vertebrae balanced gently. We don't do any twisting or popping. We're gently correcting those guys. And when we do, that brings normal neurological input back into that nucleus, calms it down, gets inflammation down, and allows for the nerve tracts to balance.
Yeah, I think it's super important too to think about, because the cervical, there's the nucleus, and then there's the cervical tract that actually comes down C1,
Yes.
So like, it's this phenomena where I'm not sure if it was this paper or a different paper, but they think about, and you can, I mean, in general, you can think about the nucleus as a router. There you go, boom, right?
Okay, so that nucleus is down here. Oh, where's my finger? Down here at C1, C2, and C3, that's the cervical input, right? So that's C1 and C2 and C3 input, and then it travels up into the nucleus up higher.
Perfect. And so the idea being with that nucleus is you can think about it like a router. And so if the information coming in from the neck, from that C1, C2, C3 is going into that router, and you have a mechanical misalignment that's distorting that in some way, then if communication's off or it thinks it's coming from somewhere else, you could have neck pain and it gets translated as pain coming from the trigeminal nerve. And so that's kind of a proposed theory of why we've seen, in practice and in case studies, the upper cervical chiropractic correction or the treatment of the upper cervical spine improve these patients.
Right.
Yeah. In the paper here, it talks about the diagnostic criteria for classical trigeminal neuralgia and then symptomatic trigeminal neuralgia. And pretty much the only difference is one, they know what the cause is, and one, they don't. The video that you did, you talked about, was it the inferior cerebellar artery?
Yeah.
Yeah, it's an artery that compresses potentially the trigeminal nerve, which could cause trigeminal neuralgia. Lesions, tumors, infections, things can obviously, if it's in the, near or having to do with the trigeminal nerve, could be of consequence as well. But I think for the patients that have been through all of these, these medical visits, and maybe they've done an MRI and an MRA and they've done imaging and they haven't found anything, but they still have the trigeminal neuralgia, that would meet the classical trigeminal neuralgia definition of not attributed to another disorder, which means idiopathic, which means they don't know why it's happening.
Right.
So first of all, patients, especially where the medical field hasn't found anything more serious, so thank goodness that they found that there's nothing more serious, but they still have the problem, so there's still a cause. That's the idea. There's still a cause to the problem. So upper cervical chiropractic could, they could be a fantastic candidate for upper cervical chiropractic care. And just again, not to marginalize other professions that treat the upper cervical spine, getting their upper neck looked at, because it's very, very important.
Right.
But even so, I think it's important that even if people find that there's a vascular compression or that there's something else wrong, they should still get their upper neck looked at, because there could still be a contribution to that. And I think one of the research papers that I'm going to do or have done and reviewed, one of the patients found vascular compression of the trigeminal nerve but on the opposite side.
Mm-hmm.
So they were like, oh, there's this finding, but you don't have symptoms on that side where there's compression, and you do on the side that's not. So it's like, well, is that a causative factor or not? It really raises some questions on, is that a factor? And if it is, would upper cervical care still help if they have that misalignment?
Right.
What are your thoughts on the TMJ having an effect, or being a causative factor, or being the effect of something like the trigeminal neuralgia?
Well, the TM joint, so TMJ is often misdescribed. It's TMD would be the problem, temporomandibular disorder. But there's a disc in the jaw. It's right next to where inside of the skull is where the nucleus is, but they're within like millimeters of each other. C1 is right behind that, C1 and C2. Right, so you've got all this input, all this neurological communication happening, and definitely I would say an occlusion issue in the jaw, a bite issue where you're constantly hitting in the jaw in the wrong spot. That's going to drive into that disc, and that disc has nociceptors that then can drive right into the nucleus. Getting the neck corrected, I think we've done Dr. Schulten's occlusion paper before, didn't we? Yep. So, So, we know that when you correct the neck, it can correct the jaw, and the jaw can throw the neck off. So it can go both ways, and it's really important to check boxes. The first place I would check is the upper cervical spine. The next place to check might be the jaw, and then to go in from there, and then maybe get an MRI, get a CT scan of that area, and see if there is vascular compression going on. And if not, there are many things that could be causing that pain coming from the cervical spine or coming from the jaw.
Yeah, I think it's fascinating to know how many different inputs and things there are that go through the trigeminal cervical nucleus, and how much of a problem that can be, especially since it kind of descends into the cervical spine, and it's not, way up in the brainstem. So, okay, cool. So what would you like to see? I mean, unfortunately, there isn't a ton of research, right? We've got case studies with trigeminal neuralgia. I mean, I've got a patient right now who's had tremendous results with trigeminal neuralgia. And
I just got done seeing one of my TM patients.
Yeah. So it's, there's some case studies out there, and I'm sure there's tons and tons of different, patients out there that have had results with this. But what would you like to see done with the research with trigeminal neuralgia? What would you like to see to kind of continue to get validation and show that we can actually help some of these patients?
Yeah, I mean, if I had my way, I'd have the BJ Palmer Chiropractic Clinic of 1935, and we'd have everything in there, and we'd be testing blood and urine analysis and everything. And one of the tests I would be doing would be a T scan, a bite scan, before and after adjustment, and looking at those patients that have that trigeminal neuralgia, and see, does correcting the neck change that bite? And if it does, and then the TN gets better, the trigeminal neuralgia gets better, it's like, oh, interesting, right? And so, I think that would be a great paper. Dr. Westerson and Dr. Schulten up in Canada have done that bite scan paper already. Malocclusion, craniocervical something rather, and malocclusion. And in that paper, they did a pre and post scan of correction, or of scan, correction, and then scan, and saw changes there. And I just think that would be really neat. And we need to get another study in PubMed. There's only this one study that was done by basically a full spine chiropractor that did some soft tissue and TENS and all kinds of other stuff up there at CMCC. But I'd love to see somebody that's an upper cervical chiropractor specialist do a really big paper on TN in their practice. And I know a lot of chiropractors who have lots of TM patients. So
yeah,
I
would like to see, if money wasn't an issue, maybe NIH, knock, knock, knock. Here's an idea: getting a neurologist on board to co-manage these patients and do a whole workup, do MRIs and MRAs and, any sort of imaging that they can find to see if they can find an anatomical reason why these patients are having the TN, and then still getting them all upper cervical care and tracking the progress to see how much improvement there is, and getting as many patients as possible. I mean, that would be ideal, getting hundreds, if not, if not thousands, but it's fairly rare of a condition, but, just getting a huge study like that, it would be priceless. It would be priceless to people that are suffering with this, so that they have more answers. In an ideal world, obviously, with healthcare and co-management, co-treatment, triaging, et cetera, the medical profession is based on triage and these charts of diagnostics and differential diagnosis, and if they have this and that, they have that, and obviously we should be a part of that. It would just make sense for conservative care. That would be optimal. That would be really cool to see, and who knows, we might see that in our lifetime. That would be really cool.
That would be amazing. Cool. And I know Dr. Burkhan up in Grand Rapids area in Michigan, he did resolution of trigeminal neuralgia following chiropractic care. I think it was just one case study. Is that the paper that you did?
No, but I will be doing that one. And I've done a couple so far, and I'm doing more in the future. I'm really trying to hit trigeminal neuralgia hard right now with the research reviews, to just to kind of build up a bunch, what's out there and what's available, at least for now. Even get some more awareness out there, and especially get it aware for people that have trigeminal neuralgia. Try to get them because nobody's telling them about this, let's be honest. And it's really sad. So hopefully they'll run across this video, and they'll see that there's a conservative option that could potentially literally change their lives. I'm just trying to get the information out there.
Yeah, absolutely. I'm looking at the 3 case studies that I have, and each of them are females. All 3 are females. So the one we're doing right now, and then the Burkhan study, and then Dr. Erin Elster, she did one, and it was a 38-year-old female. So for whatever it is, it's females tend to experience it more, and we've got a few case studies on it, but we need more. We need them in PubMed so that more people can get access to the information. So
I didn't know Elster had a TN one. I'll have to look for that one.
Yeah, I'll send it to you.
Okay. All right. Any last thoughts before you get your question of the day?
Nope. Bring it on.
All right. So what is Dr. Tyler Evans' favorite Lord of the Rings movie? Now I know. That's the tough, because I know you're a huge fan of Tolkien. So you can take this as favorite movie, favorite book, or even favorite, maybe unknown or less known work by Tolkien.
Okay, easy. I can knock this out of the park pretty quick.
Yeah.
Okay, so Fellowship of the Ring is my favorite book, because it was probably one of the first books that I read where I was like, oh my gosh, I love reading, because Gandalf fell off. If you haven't read it, spoiler, right? But he falls off the cliff at the end of the book, and you're like, no! And I was like, where's the next book? Give me the next book, right? And so that's why I love that. And then I think in the movies, probably the second movie, because it opens with his fight with the Balrog, Gandalf's fight with the Balrog, which is amazing.
Yeah.
And then even if I could say non-Lord of the Rings writing of Tolkien, I would say probably the Silmarillion, which is it's the prehistory of the first, second, and third ages of Middle Earth. That is great stories, which are very dark and but very interesting, and a lot of dragons and sword fighting and stuff. So anyways, awesome. It's lots of fun.
Awesome. All right, Doc. Well, thank you for your time, and we'll see you on the next show.
Awesome.
All right.
See you next time.
Cool. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care and take care of your spine. It's the only one you'll ever have.